Now I would like to invite Professor Messetti, who connecting with us from Sao Paulo, Brazil, to introduce himself and share with us his thoughts and research. Thank you so much. Professor Messetti.
Hi, Professor Margosata. It's a really good pleasure to be here today with you. Thanks for the precedent conferences that showed us some fundamental ethical and legal concerns about medical sourcing during a pandemic. Thanks for David Ford that is also here. I'm a Brazilian lawyer, and I have a master degree in bioethics, and I am PhD candidate in health sciences in Brazil, in São Paulo, and I deal with in my days with patients' rights, health professionals' rights, and also health insurers' rights here in Brazil, and public health. I made this presentation according to this invitation of the Polish Academy for Science Academy in Paris, and I'm really happy with this invitation. And now I'm going to share with you my my contribution to this day. Okay. So the theme of my presentation is about the health and liberty rights in the context of health systems protections during the COVID-19 pandemic. So there are, for the beginning, a very important issue to deal with that are the bioethical challenges. Are there the biomedical principles enough for facing the pandemic and these challenges arise in these contemporary days? So the theory of principles limits, as some theorists says that limits the possibilities of argumentation for bioethical hypotheses. So situations such as global bioethics, environment, social exclusion, for example, would be beyond the scope of the four biomedical principles that arise from the Belmont report and the conception designed for by Beauchamp and Childress. So the references of bioethics, the bioethics references as principles and other elements can be called nowadays, can be bridges of references of connection for bioethical reflection. So to make resolution and consideration not only constituted by rights and duties, as rights and duties can be deontological and physiological principles. So we can use another kinds of references to deal with the ethical challenges and situations. According to late Professor William Saad Husni, a Brazilian bioethicist, rights, duties, and values, commitments, and ethical feelings in full freedom of pluralistic, inter- and transdisciplinary action, aggregating biological sciences and other branches of knowledge, above all human, social, and also exact sciences, can constitute the optics and metrics of the theory of the references, like instead of talking about the biomedical principles only. So the biomedical principles can be increased by other kinds of references, so like justice, dignity, solidarity, fraternity, confidentiality, privacy, vulnerability, responsibility, survival, quality of life, as non-exhaustive examples. So This shows a tendency to dissociate the bioethics from the ontology. Also, in a presentation by the Commission, the European Bioethics and Biolaw Commission, the Biomed 2, taken between 1995 and 1998, it was proposed for biolaw and other principles than the biomedical principles, also in number of 4. Autonomy, dignity, integrity, and vulnerability, highlighting that these all 4 principles express dimensions of the human being that must be respected and protected. And 3 of them, dignity, integrity, and vulnerability, also concern the protection of animals and living organisms. So, as we can see, the fact of placing vulnerability between these principles, which is neither a right nor a duty, but a condition, so it makes eloquent proof that there is a tendency of dissociation of bioethics from only the ontology. In this concern, we could make a summary of the role of ethics in health decisions making during a pandemic. So the main aims of the decision making in a pandemic, such as the one that we are dealing nowadays, is to giving priority to health rights and to protect the population for access to health systems. Also to prevent the loss of life that can be saved and prevent the system from collapsing. On an ethical basis, promote respect for the principles of justice, freedom, solidarity, life, and human dignity as the main important things. So the choice of extreme measures in a pandemic such as ours nowadays is related to the issue of collision of fundamental rights. In constitutional level, principles or values are the norms that, by prioritizing the exercise of certain rights over others, require investigation of the scope of the protection of the principles and reasonable justification in the Constitution for government decision-making. On the other hand, the right to freedom is not absolute, and no other fundamental right is absolute, as they are situated in relation to other rights, for all the rights has their value. So they are relative. So health rights are declared in international standards and are internalized in most countries' constitutions as effective rights, and have to be balanced between freedom rights, for example, during a pandemic. We could research in our program and laboratory of public health here in São Paulo that scientific data from past pandemics and from COVID-19 already indicated, according to our studies, late in March and April of 2020, that extreme measures of health-based restrictions were effective in containing the viruses of precedent pandemics and also during this nowadays pandemic. In this context, it's important to explain the right to health in a pandemic as a prioritization of the fundamental right of health in a collision of rights at the constitutional level. So when we meet the solidarity and the just freedom in times of a pandemic in a constitutional level, we find that in a constitution like ours in Brazil that constitutes the health rights as constitutional fundamental rights, it's necessary to prioritize the right to health in face of the exercise of freedoms disconnected from solidarity. So the Constitution, in decisions of the American and Brazilian Supreme Courts on the collision of rights, as we will see after during this presentation, takes decisions as we just explained. For instance, we are just making a comparison of our public health system that we call SUS and the revenues of the supplementary health system, like the health insurers in the year 2019 in Brazil. So the population in Brazil was in 2019 it was 211 million inhabitants. So the SUS budget, our public health system here, was of 122.6 billion applied reais, Brazilian money, in the year 2019. Approximate expenses in health care by the health plans at the same period until the third quarter of 2019 was of 170 billion of reais. When we talk about the expenses of the public system here in healthcare at that year, it was of 93 billion reais, and the population of health plan beneficiaries at that year was of 47 million beneficiaries. As we can see, the revenue of the health plans and the health insurances in Brazil at that year, until the third quarter of the year, was of 210 billion reais. So it's not proportional to the population. So we have 211 million inhabitants, and we have a budget of the public system to make the healthcare assistance to all Brazilians and foreigners that reside here, of a kind of 122 billion in 2019, and the revenue of the health plans was just kind of 100,000 billion more than the budget of the public health. We can see here it's a curve of the official Brazilian death curve from 2015 to 2021, and we can see that in 2021, in March, there is this increase. If we see the historical brand from the March, from the month of March, from 2015 to 2021, we have year after each year an increase of 5 to 10, 15% of the of the quantity of deaths, and then in 2021 we have this huge increase that is much from 100,000, about 100,000 deaths in March of 2020. It came to 180,000 deaths in 2021. It is a reflection of the actual pandemic. So we had this huge increase, and that justifies extreme measures to be taken. So as I referred before, Supreme Court's decisions that we picked from the U.S. Supreme Court in May 29, 2020, rejected a church challenge to California's COVID-19 restrictions by 5 to 4 votes. And a conservative minister judge said that the Supreme Court will not facilitate the spread, would not facilitate the spread of a deadly virus in the name of the First Amendment. So there is clearly a collision between the health rights of the people and public health. And also, as we think about the American context, there is not a health rights constitutionally based, but as we can see in a way of ideas and ethical ideas, we have this collision of health and freedom, and the decision here was to prioritize the health and the public health. In Brazil, it's not different. So we have this Supreme Court recurrent and precedents deciding that when health collides with other fundamental rights such as freedom or other rights, the solidarity of related to this necessity to maintain the health prioritization is made in decisions to make the access of the health rights possible. So it is also a way that always must have this consideration between health rights and also freedom rights. As we could see, when we make decisions in health, and we have this extreme character of these decisions in a pandemic, it depends on the ethical and also on the legal adequacy of this decision to the Constitution and to the countries and international standards of health and ethical considerations. And these acceptable standards are based also in the literature and science that can provide this big picture of how we need to access the prioritization of rights in a collision. So what we could understand by our study is that to take an extreme measure in pandemic, this decision has to be based on solid facts that justify this extreme decision. If there is no scientific evidence given to the novelty, so if we have a scientific evidence that points to a kind of decision, it has to be prioritized, and then the best available scientific evidence has to be the guide to take this decision. So it has also to be based in the least amount of risks to public and individual health, and has to prioritize individual and collective rights in our context in Brazil. And it has also to not directly harm the health and dignity of any person's life, and presumably has to be unable to harm anyone. And also, and really important, is that these decisions have to better favor the most vulnerable people. The extreme decision in a pandemic will be fair if it respects the Constitution, the individual and social fundamental rights and human rights and international rules, if it's valid for all persons under the same conditions, or if it is valid for one or more persons with specific conditions. So it also has to be taken with the least aggressive efforts to achieve desired public health goals. It's not desired to take a huge effort to restrict all the freedom of people if we don't need this to make it possible the public life of everyone. If we can use masks, if we can make this isolation of and testing the necessary infected in a pandemic situation like ours, it is much more effective than isolating and making huge lockdowns. But at some points, lockdowns are the only way to face the spread of the virus when other measures, also restricted, could not face this face this pandemic situation. And also, it's really important that we face proportionality between the public health measure taking and the risk faced, and it is related to our explanation. For the last, we published in last January in the journal Frontiers in Public Health an article of our group based on some of these considerations that we could show here for you about this collision of fundamental human rights and the access of people to health systems during this novel coronavirus pandemic. Thanks very much, and I am available. This is my email and my graduations. Thanks, Professor Organizada and everyone.
Thank you very much for this interesting presentation, also showing us the context of Brazilian healthcare system. We had a chance yesterday to look at the context of the US healthcare system, so it's very, very informative. Now I would like to invite David Ford to present his thoughts and findings. Also, a warm hello to our colleagues watching from the CDC quarantine station in Boston. I know you are there, so hello. And David, this is your 10 minutes. Thank you so much.
Thank you so much, Dr. Margaret. And, thank you so much for the opportunity to be here today. Don't have any slides, so I'm just going to be just talking about a number of different issues that relate to the topic that's here. And I appreciate the opportunity, absolutely. A couple of things. First is that, I've told many people for many, many years that, this whole, the public health system has always been pretty much in the shadows. And a lot of for us in the industry is that we're not really talked about, we're not really seen until something like, for example, COVID shows up, and then we really have to step up and then let people know how important our field is. I've been in the field of public health for over 30 years, and I have master degrees in public health, healthcare policy, business, as well as finance as well. And also I've spent a lot of time in the political realm as well. So for me is that I've seen a lot of different moving parts in all those different areas and see how those all can be combined. And I think in this situation with COVID, the global COVID crisis, all of it has been working together, collaborating together in one way or another. So just a couple of things here is that currently I have two different opportunities going on at the same time. So the first thing I do is that I work for the CDC, Centers for Disease Control and Prevention. And what I do is that I work as a public health advisor, basically trying to mitigate the transmission of COVID coming into the United States, and also globally. So it is really a big collaboration between the quarantine stations in the United States. There are many throughout the nation of the United States. I happen to be in the Boston area, but they're all over the entire country. And we work with health departments from the various places, other quarantine stations, the FAA, the border control, many different areas, many different institutions within the government in order to try to mitigate the spread of COVID. Some days are more challenging than others. We have some people who, obviously it is a burden for many people. Passengers are trying to come into the country and so forth. They have to have a negative COVID test 3 days prior to them coming into the country. And sometimes when they do show up into the country, we have to still, check their documentation to ensure that they have the proper test. And that also goes for animals that are being transported into the country as well, whether it's for scientific reasons or for personal reasons. We have to be really diligent. So, it's a large group of people, public health policy individuals, epidemiologists, medical facilities, medical people, all working together in order to make this thing happen every day. And the global transmission is critical. I mean, we all have to work with all the different airports to ensure that nothing, transmission of this COVID is not being spread internationally. So it is a reliance on each other. And trust, even though we may not necessarily know each other from the different departments and the headquarters, and also from the different airports or even countries, to basically collaborate in order to make sure that the mitigation of COVID is realized. So that is really, really, really critical. Also, outside of that, I'm also a clinical bioethicist. And what I do is that I try to advise hospitals, healthcare organizations, public health organizations, and corporations, as well as individuals, families in the ICU and patients in the ICU and different areas, about basically how to make those really tough medical and healthcare decisions, especially when during this time of this global crisis. I tell everyone that what we're dealing with here is just liken it to World War III. We're not fighting each other. We're literally fighting something that is invisible. And we have to make sure that we all have to collaborate in all these different areas. And what I've seen in the healthcare arena is that, it is, as you've seen on the television, lots of different, it's so many different parts, from the medical staff, the PCAs, the respiratory therapists, everyone trying to work together to try to give the best care to patients who have COVID. It is very, very trying, very, very trying to see how some patients have just been really, really sick, how the families have had to deal with the trauma of seeing their loved ones sick. I've been in some of those ICUs. I've seen the dilemmas about how to make decisions about patients and so forth. And it's very, very, very difficult. Very, very difficult. And, what I would say is that, you don't want to be in that situation. I know for many of us, we've known people who have been sick. Some of us have known people who have passed away. But when you're in that situation, it is a very, very difficult and trying time. But what I did see during this time is that the tremendous collaboration between the different areas, the different professionals, different levels in order to provide care. And we have to make sure that we continue with that once we emerge from this crisis. One thing that I was concerned about as a clinical bioethicist is that in some cases where there was a rush to remove people from the ventilators, remove care. And I was concerned about that because you're dealing with obviously people's lives. And I think what I was concerned about was the violation of the bioethical principles. And obviously, no one wants to violate those principles, but at the same time, there's an issue and concern about scarce resources, trying to prioritize who gets a certain product or a certain technology, and how much of that was something that was really concerning. But at the same time, we have to be very careful about not violating those bioethical principles. That is something in the field that we have to make sure that we stay to, that we don't violate and try to mitigate. Even though we're stressed out and we have sometimes very scarce resources, we have to make sure that we do the best we can. And that's another thing too, is that the scarce resources, I think, I know that for many people, not in the United States, but all over the world, we were caught off guard. And so those resources were in many places, even the United States and many industrialized countries, were very scarce. So we have to make sure that in the future that we always have a stockpile, and also access to this should be freely throughout the country. Should be better than what we're doing here. Certain geographical areas shouldn't have more than another if the need is the same. So there's something to definitely think about. One thing also we noticed was that the inequities here in the United States, and I know this is around the country, around the world as well, but here in the United States, this COVID crisis totally spotlighted the inequities between the haves and the have-nots, the different racial and ethnic groups who don't have access to quality health care. We saw that in the Black and Latino and Native Indigenous communities, the Native American communities here in the United States. We also saw that in many rural areas. So we saw definitely the inequalities. The inequalities have always been here. The question is whether or not we're going to continue to, stay on the same path and not invest to try to reduce and mitigate those inequalities, or we're going to do better. To me, by not investing and not taking care of the individual when it comes to providing quality health care, to me is a violation of the bioethical principles. You should be, especially the one of beneficence, we should be doing everything we possibly can to ensure that people get the best care, and that we're doing things, taking actions to help those who need it. So, we have to do better It has a healthcare system. We have to do better as a country. From a political standpoint, we have to do better. One thing, like I just mentioned a second ago, is that we have to be better prepared. I started this presentation about basically the spotlight. Right now, the spotlight's on our fields: bioethics, public health, healthcare. And again, it's for many people, they don't think about these things. They just, pay their money and they go to their doctor when they need to, or public health. It's some type of, not necessary thing. Sometimes the world of public health, for example, is not very sexy. It's not the finance world. It's not the movie world or something like that. But what it is that is extremely, extremely important. We saw a clash between the different areas this year. So we had public health initiatives, we had public health things that we wanted to do. But we saw, and I always tell people this, is that one of the biggest things that we saw during this crisis was the strength of the political realm. So even though the public health realm would come out and give advice and make recommendations and tell the politicians what needs to happen, is that we had the politicization this fight between politicians, about whether or not this COVID-19 virus was even real, which obviously costs lives. When you politicize a virus, when you politicize a mask that could save your life, it can really make a big difference. I have somebody I know who was one of those people who bought into the myth that masks, first of all, the virus doesn't exist, and B, they should not wear masks. Well, that person is now disabled, and they're really young. They're in their 30s right now. They got sick, they got COVID, and now they are in really serious trouble. Disabled, can't work. Because they bought into the myths when it comes to the politicizing of this virus. So, and then you saw the strength of the political realm, because you saw how on the federal government here in the United States, they recommended, they can't force, but they can recommend to the 50 governors or more governors, if you include the Puerto Rico and some other entities, basically to lock down or put in a mask mandate and so forth. And you had a lot of conflict, a lot of issues, and many governors went their own way. Bottom line is that when it comes to these public health issues, we can't have the politicizing of these issues, especially when it comes to our lives. You just can't do that. And we're trying to do a balance between the rights of the individuals here in the United States. We have a lot of freedoms here in the United States, but at the same time, we have this public health concern, and sometimes the public health concerns have to supersede what we want individually. So we just have to keep that in mind as well. And the last part I just want to say is that this was a really good opportunity for all of us to work together collaboratively around the world. We have to make sure that we continue to strengthen those bonds. And if we can do that, I think we'll be better prepared the next time another COVID-like situation happens, because it's going to happen. I was in public health school 25 years ago, and my professor said this was going to happen. So this is going to happen. We have to be much more prepared on all levels. Well, thank you so much for the opportunity.
Thank you very much, David. Thank you very much, Paulo. I would like to ask Professor Pawlikowski for concluding comments. If there are any questions, quick questions to our speakers, please go ahead. Daniel, if you can come here, then the speakers can see you as well.
Thank you so much. Can you guys hear me? Yes. Thank you so much for the amazing presentation on bioethics and especially the COVID pandemic and response. I was just really curious because with the COVID response, there was a lot of communication and information. So I wanted your take on bioethic or ethics and risk communication during the pandemic.
Just want to make sure that you heard the question.
Was it about communication between the different levels of individuals or countries or organizations? Is that the question?
The question was on ethics and risk communication. Just giving the different controversials and communication during the pandemic. I wanted your point of view on your opinion on ethics and risk communication during the COVID-19 pandemic.
Risk communication, okay.
So,
Go ahead.
good. Thanks, Professor. I don't know if I understood really well what the question was, but about miscommunication on bioethical field in the pandemic. So I can see, for example, this questioning about the official number of deaths, for example, in Brazil. So we have this huge increase of deaths, and we have the official numbers, and we have this problem also mentioned by Professor David, that politicization of pandemic issues could make it impossible for us to count the dead. So also during last year, the Brazilian government tried to not make it public day by day the number of the deaths. So I can understand this is a kind of miscommunication about this fundamental pandemic issue. It happened, and we don't know exactly if we had 180,000 deaths in 2020 in Brazil, or if it could be 300,000. So it's something that we can, in some years, in epidemiological studies, make more certainty about this issue. Thanks.
Much. This concludes our panel on law and bioethics. Again, David, Paulo, and Jakub, thank you so much for your contribution. And I hope that we can all continue this conversation later in the time to come. Thank you so much.
Thank you very much, professors.
Thank you so much. Everyone be safe.